So, as I said, I can see a couple of people, and hopefully you can all hear me okay. And we will take a moment every now and again just to check in with each other. So, if we make a start, so Marie, next slide. I've got Marie Cooper here. Oh, I now have control of the mouse.
Yes.
So, which one am I using? Okay. So the areas that I want to cover today, you can see there in front of you, hopefully. So what is nutritional screening? Why should we do nutritional screening? The key part, I think, is about nutritional screening tools and what kind of tools people are using. And then thinking about after screening, what do you do next? Because it's all very well identifying that people have difficulties, but it's really important to think about what happens next. Okay, so actually, shall I do it? Okay, so I've put some definitions there of a definition there of what nutritional screening is. So Shaw and Eldridge, Claire Shaw is very well known in cancer care. She's a dietitian. Describe nutritional screening in palliative care as an important aspect of holistic care. And I think that that's actually really important to remember, actually. I think the holistic care is key. What we're providing in, I mean, I can speak from hospices because that's where my area of expertise is, but I feel very passionately that we are delivering holistic care, and nutrition is a key part of that during the palliative course of somebody's illness, as well as at the end of life. So I think that that is an important thing. The Department of Health says that organisations have a duty to safeguard service users from malnutrition and from dehydration, to identify poor nutrition and dehydration with screening, and to take action to treat it. So again, it's the doing the screening and taking action that I think is really important. And again, in a palliative setting, we have to think carefully about what does that mean. And as any of you who have already had a CQC inspection will know, or those of you that might be preparing for it, nutritional screening and what we do with nutrition is monitored by the CQC. Now, I feel quite strongly that just because somebody's monitoring it, that isn't the reason for doing it. We're not doing it to tick boxes. We are doing nutritional screening to make sure that we're identifying problems for our patients. The fact that it's monitored, I actually think, is a very positive thing, because it helps give organisations the kind of commitment to addressing nutrition as part of somebody's holistic care. So I just have picked out from the CQC key lines of inquiry. Now, again, I'm not sure how many of you have had a CQC inspection. For hospices, I imagine that most of you will have done, because I think the aim is that most hospices will have had a CQC inspection. But I've taken an extract from the assessment framework, and there's a link there so that you can go to that yourself. But under the key line of inquiry around being effective, where effective means that people's care, treatment and support achieves good outcomes, promotes a good quality of life, and is based on best available evidence. And I think, again, the key there is about good quality of life, because much of what we're doing with nutrition in a palliative setting is thinking about the individual's quality of life. So E1 under effective asks, are people's needs assessed and care and treatment delivered in line with current legislation? So that emphasis on assessing the individual's needs is there. And how, E15, how are people's nutrition and hydration needs, including those related to culture and religion, identified, monitored and met? and where relevant, what access is there to dietary and nutritional specialists to assist in this. So I think it's fully embedded in the CQC key lines of inquiry. And I think, as I say, that gives us a good reasoning for why we should take care around people's nutrition and hydration needs. I am not implying at all that any of us are not paying attention to people's nutrition and hydration needs. I just think when you are thinking about your organisation and how you might, what evidence you might use to help make a case for dietetic input, for example, or make a case for having link nurses around nutrition, I think having that information there, I think, is quite important. And I've just extracted the ratings characteristics. So we have, I put the outstanding and good. So for those, I'm sure everybody aims for outstanding, and here the characteristic is a truly holistic approach to assessing, planning and delivering care and treatment for all people who use them.
Share your webcam, yeah, so they...
Oh, sorry. And this includes addressing, where relevant, nutrition, hydration and pain relief needs. So again, I've taken that extract where it specifically refers to nutrition and hydration, and for good, people are having comprehensive assessments of their needs, which include consideration of clinical needs. And again, nutrition and hydration comes in there. So, as I say, I wanted to include those so that you kind of got a background as to why this is important and things that you can use for your cases. Right, I might just need to mute.
Randy Attaway needs to come.
Is everybody okay? Everybody can hear and see if that's appropriate?
Yeah. I've muted them. I don't know why she's coming through.
Yes, the sound's very clear here.
Okay, great. Lovely. I just wanted to just check in, make sure everyone's okay. So I kind of... Lovely. So I'll continue. So having set the scene as to why do we think about nutritional screening? What is the actual purpose of nutritional screening? So it's all very well, we say that we screen, but why are we doing it? So the purpose really of screening is to identify malnutrition. And the reason is malnutrition results in a range of, there's a wide range of impacts of malnutrition. So I've put some of them there. So increased risk of illness infection, slower wound healing. There might be an increased risk of falls for people who are malnourished. People might find it difficult to keep warm. It can certainly impact on mood, reduced energy levels and reduced muscle strength. Now, about rehabilitative palliative care, which I think a lot of areas are, we're thinking about how to maximise what individuals can achieve within their life-limiting illness. So, avoiding malnutrition or reducing the impact of malnutrition can help to reverse some of these things, reduce energy levels, reduce muscle strength, so that people have got that little bit of energy so that they can engage in the activities that are important to them. And while I realise that for many of our patients, weight gain may be quite difficult, especially due to the impact of cachexia, which I will talk about in more detail in the next webinar. What I often talk to my patients about is trying to minimise weight loss, so that people may still lose weight, but where we can, we try to minimise that. And also there's a very big psychological component in people's ability to eat and drink. And again, we will talk about that in more detail in the next webinar, because I feel that that owes a session for itself. But they are some of the reasons why we would be screening.
What's the Mandy Attaway to turn the mute button on?
Okay. Mandy Attaway, I'm sorry to name you. Mandy, do you think that you could turn your mute button on at this point? I hope that's okay. And we'll open up for comments shortly. Thank you. So many of the patients that we see in hospices will be malnourished, will be undernourished. And do you remember we talked the last time about what malnutrition is? So I'm not going to go into a lot of detail this time. Mandy, you don't seem to have any sound at your end. I'm sorry, I've just seen.
Yeah, you carry on.
Okay, so I'm going to carry on.
You can get these things.
Yeah, thank you. So some of the reasons why people will be undernourished in a hospice setting, the disease. I mean, as I mentioned, for people with cancer, cachexia is quite a significant issue. I do apologise, I've just realised I've left my phone on. That is the most terrible thing for the presenter to do, so apologies there. So the disease is going to be affecting people's nutrition. So whether that be a physical effect, such as a blockage somewhere along the GI tract, and if we think about going right through from head and neck cancer, people with esophageal cancer, and then people who may have bowel obstruction as a result of treatment, or their tumour, for example, the disease in itself is going to result in people becoming undernourished. If we go to the next. Oh, sorry. Okay. The effects of treatment. You'll have all have seen this. Obviously, if people are having chemotherapy, radiotherapy, they can have a major impact on people's ability to eat and drink, to appetite, causing symptoms like nausea and vomiting, intense fatigue. All of those effects will impact on somebody's ability to eat and drink, and so their nutritional status. Many of the patients that we see will be low in mood, and I think we can empathise with that. Sometimes, well, I mean, we see patients who are very, very depressed, very low in mood, and eating and drinking is very low on the list of priorities, and becomes something that is very difficult for people to manage. People will often come to me with generalised poor appetite that they've had for long periods of time. It might be their treatment, it might be their disease, it might be the fact that they are much less mobile than they used to be, they're not out and about doing the things that they used to do, and that can affect people's appetite. And then cachexia itself, which we will talk about, as I said, in more detail. And the thing to think about with malnutrition is whose responsibility is it to recognise it and to treat it? Now, I know that many hospices don't have their own dietitian. It isn't just the dietitian's responsibility, and I'm sure that you will all be familiar. It is everyone's responsibility. So that's why nutrition screening, I think, is very important, because that makes it everybody's responsibility. If you're doing nutrition screening very early on in somebody's admission, or when they're accessing your service, whether that be an inpatient service or an outpatient or community setting, then I think that really helps us to show that it is everyone's responsibility. We're just doing a little bit of fiddling at this end because one or two of the participants unfortunately don't have any sound. Okay, so we'll see if we can reverse that. So, what the basics with nutritional screening? So for me, the basics are having weight, height, and body mass index. And we'll talk a little bit about calculating BMI in a moment. And And what I think is really, really important is weight change. So it may be that an individual's body mass index is within the healthy range for their height, but that individual may have lost significant amounts of weight over a relatively short period of time. So I think it's really important to record, personally I think it's important to record weight and height and calculate BMI. But I think getting a sense of weight change and what has happened to that individual's weight over a period of 3 to 6 months, I think can be really, really useful in identifying where there are difficulties for somebody with regard to their nutritional status. So I think if I can just turn on the audio and just find out how people are with calculating body mass index. So is that somebody that people are, is that something that people are familiar with? Or if you want to write in your chat box if that's easier. I can't.
Yeah, the body mass index for Sue Ryder is used, but I think, as you said, a lot of people are worried about this because they're more interested in whether they've lost a significant amount of weight rather than them fitting, you know, that categories in the BMI. So I think people tend to focus less on the BMI and focus more on weight loss.
Yes, yes. And I wonder if anybody else thinks similarly, whether it's more about the weight loss than the actual BMI. But that is certainly something that I would agree with. Because although low BMIs should be an indicator that somebody has potentially got a problem, I think that weight loss element is really, really important. I'm also interested to know what people think about weighing patients in palliative care settings. So if you can speak to me, then that would be great, or if you can put something in the chat box. Do you or any of your colleagues have any concerns about weighing patients in palliative settings? Sorry, I didn't quite catch that. Sorry, I couldn't quite catch that comment. So somebody has put up that they don't weigh their patients. Did anybody else put in the chat box or say what they think about weighing patients?
Weight reflects a snapshot, which BMI provides.
Okay, so somebody has said, and I think this is a very valid point, that BMI is providing a snapshot at that moment, but weight loss over time is giving more of an idea of what's happening. Tom, we weigh patients when they're admitted, great. Donna, which is Catherine, I think, we should routinely weigh patients unless they are having.
We wouldn't.
Oh, sorry, you wouldn't. I can't read that fast. We wouldn't. You wouldn't routinely weigh patients unless they're having treatment. Okay.
Option to use visible signs of weight loss.
Yeah, and we'll come to that.
If appropriate, we do it from time to time.
Yeah.
We don't weigh our patients. Agree. So was change natural weight gain.
Okay, so there's a mixture of comments there. Some places don't weigh, some places do weigh. I wonder also what patients think about being weighed, because are we not weighing people who are worried about what they might think about being weighed? Or are patients concerned about being weighed, and are we concerned about raising their distress by weighing patients? Which I think is a very valid reason for not doing a weight. At St Joseph's Hospice, where I work, we do weigh patients if they're well enough to be weighed on admission. So my routine is that I will ask for everybody to be weighed. If they've come in for an end of life admission and they are dying, then obviously we do not weigh them. If people are in for a symptom management admission, which many of our patients are, they might not be well enough to be weighed on the day that they come in as part of their admission assessment, but they may, as the admission progresses, as their symptoms are a little bit better managed maybe, then I would make sure that somebody is weighed. We do routinely weigh people. Our default is to weigh people unless there's a reason for not doing it. If patients don't want to be weighed, we won't weigh them. We're not going to add to people's distress by proving with the scales that they've lost. I'll talk in stones because most of my patients talk in stones. You know, if they've lost 2 stone, they don't need the scales to tell them that.
Tom asks how often.
How often? Tom, ideally, well, always once, always on admission, and ideally, I would be weighing during admission for people that I felt it was needed for. Being realistic, unless I specifically ask for somebody to be re-weighed, patients are usually only weighed the once. Okay, so again, it is a snapshot. For people who are in for symptom management admissions, then I think it is justified to weigh them every couple of weeks. I mean, if you're following MUST and on a hospital inpatient unit, you would be doing it weekly. Well, ideally, you'd be doing it weekly. I don't think people need to be weighed as often as that. But where people are in for a period of time and there's a nutrition intervention going on, I think people should be re-weighed to see if the intervention is appropriate for that person. In general, I find that our patients are quite happy to be weighed. They seem to take it as routine. I think because, especially say for people who are having palliative chemo, they get weighed when they're at clinics anyway. They get weighed by their GP. They get weighed all over the place. So us weighing them doesn't seem to cause too much distress. If people don't want to be weighed, then we'll ask them what their most recent weight was, or do they know how much they weighed. So that's what we do. Now, somebody has said that most of their patients are community-based and attend day care only, so no inpatient facilities. And again, for people in the community or for whether you're seeing them in a day setting or in their own homes, I would just talk to people. I'd ask them, have they been weighed recently? What was the weight? What is happening to their weight? Okay, so that it is brought up, even if you can't get an accurate measure at the time. At St Joseph's, we also have a respite unit, and patients come in maybe every 3 to 6 months. And getting routine weights for those patients at the beginning of each admission is really, really useful, especially for our neuro patients who, for example, might not be able to be weighed at home if they're having to be hoisted. So I will certainly use that opportunity and often share that information with my community colleagues. And somebody said about using different things if you can't weigh the patient. So if you have a think about, and again, I'll see if we can do some feedback. Can you tell me what kind of things you would look for if you can't weigh your patient? Anyone wants to speak or put it in the chat box?
Clothing.
Clothing. Yeah. Clothing. Somebody else? Yeah. So, okay. Sorry, I can't hear for some people. Yeah. So, asking if people have been weighed. We've talked about the fit of the clothes. I mean, you see it all the time, don't you? I see little old men who come in their suit and tie with the shirt collar that's obviously 4 sizes too big and the jacket that used to fit a much bigger man. So you really do see it. People's belts tightens and tightens. So the fit of the clothes is very good. Things like loose rings, loose watches and jewellery. So I'm sure you'll see this. You see the watches that's almost up at somebody's elbow because of the amount of weight they've lost. And very loose dentures is often a sign that somebody has lost quite a lot of weight. Somebody's asking about mid-arm circumference.
Yeah, visual signs, indentation of temple, loose clothes.
Yeah, great. So all the similar things. I don't actually do mid-upper arm circumference. But it can be quite a useful measure as a serial measure. I think as a one-off, it's not going to tell you a lot more than BMI or the weight at that day. But again, if you've got the opportunity to measure the mid-upper arm circumference sequentially over a period of time, that can be useful for people that you can't weigh in other ways. I think you have to make sure that you've got, if there's one person doing it, then there won't be much user error. But if more than one person is doing it, you have to think about inter-user error, because although there are certain points that you will measure from, we all do things slightly differently. So, there we go. So I've put up about the MUST, the Malnutrition Universal Screening Tool, and I'm terribly sorry, I can't remember the name of the lady from Sue Ryder has already mentioned about using MUST. It would be really useful to get a sense of how many organisations are using MUST as their screening tool. So if you put that in the chat box, if you can, as we go along, or if anybody's using MUST. Is there anybody using MUST? I think some of you probably know. Someone, Sonia, not currently using MUST. Christine, you are. Jenny, not using it. Okay. No, so quite a few people are not using MUST. And why are you not using MUST? I think that would be quite interesting to know. Perhaps type it in the box, and then I can pick up those comments quite easily. Don't use MUST. No, so somebody else not using it. Don't use MUST. Okay.
I reckon our policies or staff why that does not fit.
Yes, it doesn't fit, and I feel that about MUST as well. I don't think that MUST fits our patient group, because if you go through the 3 steps of MUST, I think the vast majority of my patients, of our patients at the hospice, will score high enough to be referred to a dietitian. I don't think it's particularly sensitive in palliative patients. And also, MUST doesn't really take into account everything else that's going on for people. So I think MUST is a bit broad brush. I just think it's not a very sensitive measure. And if you haven't got a dietitian to refer to, that can make that quite difficult as well. So somebody says that they agree, although
We don't follow completely because we often don't weigh.
yeah. So that's, sorry, someone's putting in a comment saying that because they're not weighing the patients, then using MUST, is probably of limited value. You can still do estimates. I suppose you can ask the patients what their weight and height are, so you can estimate BMI. But if you're not weighing patients, then MUST isn't going to be a particularly useful tool. And somebody asked about validated tools for palliative care. And as far as I am aware, there are no validated tools for use in palliative care. So I'm really sorry that I can't give you reference to that. I've taken a poll of some of my dietetic colleagues who work in palliative care settings in hospices around London, and nobody else is aware of a validated tool. Everybody is using their own tool. Now, in that group, so there's 3 or 4 dietitians in that group from St Christopher's, St Joseph's, where I am, Princess Alice, and the Marie Curie Hospice in Hampstead. As part of that group, we are going to be doing some work in the year ahead, looking at nutrition screening tools, and maybe working towards developing a validated tool for use in the palliative care setting. That sounds like quite a big piece of work, but I think it actually would be a very useful piece of work. At St Joseph's, we've developed our own tool, and this is probably very similar to what everybody else has done. So it's a screening tool, and it's unvalidated, and it's what usually the healthcare assistants on the inpatient unit or the nurses in the community setting will use when they do a first visit or when they see people at home. And actually what we're trying to get here is identify people who are at risk of malnutrition and pick out lots of other information for referral to other colleagues. So we do, as I said, look at the weight, height and BMI and weight change. We also ask questions about changes in appetite, because often people have had those kind of changes, and they might not have lost a lot of weight, or they might not feel they've lost significant amounts of weight, but actually the appetite has changed. We look at need for texture modification, because that will also help identify if somebody needs a speech and language therapy referral from a dysphagia point of view. I'm always interested to find out whether people are on nutritional supplements, because often by the time I see patients in the hospice, they have had input from lots of different places, maybe from a community dietitian, maybe from a dietitian at a clinic in the hospital. Maybe their GP or district nurse has already highlighted that there is a difficulty and they're already using supplements, or they've been prescribed supplements. So being prescribed supplements and using supplements can be a difference in those two things. We pick up comorbidities such as renal disease, diabetes, that might also be impacting on eating and drinking. And we also think about the psychosocial impact of poor appetite. So how are you feeling about your eating and drinking? So again, it is quite a broad screening, but it does help identify people who have got specific difficulties. And
Ayrshire Hospice have developed a tool.
Great. So Ayrshire have developed a tool, Ayrshire Hospice, but it's not validated. Maybe we could get in touch afterwards and have a look at the tools and think about whether that is a piece of joined up work that we could do. So I'll talk to Maria afterwards about how we can maybe gather some of this work together, because I think one of the things about working in hospices, we're flung far and wide and we're quite small. So to actually have the opportunity to do some work collectively, I think would be really, really valuable. So I really welcome that opportunity. At St Joseph's, we use Crosscare. So some of you will be familiar with Crosscare. It's an electronic patient record, and you can see the nutrition. It's still called nutrition assessment on this window of Crosscare. We're just about to change it to nutrition screening tool, because this is actually what it is. And that goes through all those questions that I had on the previous slide. And you'll see that there is a standard there. If the BMI is less than 18, then refer to the dietitian. So that's a prompt for people to refer to me. But also if people have lost significant amounts of weight, which you can see in the boxes below. And actually I can show you on the next slide. Oh, sorry, let's go back one. So we also have drop-down boxes that pick up on symptoms that might be affecting appetite and the options. So where you see med in brackets, that means think about referring to the medical team, which normally happens anyway because people are often in for symptom management. You will see SLT, so number 9, they're difficult to swallow. So that will prompt a referral to the speech and language therapist. Shortness of breath will prompt referral to speech and language and to dietetics, because people who are short of breath often find it very difficult to eat. Recent chest infections, again, might prompt a referral to the speech and language therapist. We are just reviewing this nutrition screening tool, and I'm just in the process of doing that at the hospice. So this may change in the next month or so, but it will be similar. Because what we're just trying to do is pick out the things that might not be so obvious that might be impacting on somebody's nutritional intake. And I don't know how many of you are using IPOS as part of your assessments of patients. So if anyone's using IPOS, perhaps you could shout out via the chat box. So yeah, I can see a few people. Yes. Yep. So IPOS, yep. So you are using IPOS. Lots of places out there. Sorry, let me just see. So this is our IPOS screen. And you will see and you will know that there are questions about rating, nausea, vomiting, poor appetite, constipation, sore or dry mouth. And patients will be asked to score them from 0 to 4, where 4 is that symptom is affecting them overwhelmingly, and 3 is that it's affecting somebody severely. And also, patients might identify appetite, weight loss, food intake in one of their 3 main problems. So IPOS, I think, can be quite a useful way of picking up people who are having difficulties. It isn't a screening tool per se, but it is a way of finding out if appetite and eating and drinking is a problem for that individual person. Of course, they may be losing lots and lots of weight and not consider it a problem. Whereas from a clinical point of view, you might be concerned about malnutrition. So I think it's difficult to use it on its own. I think using IPOS along with weight change, I think, is quite useful for identifying people who are having difficulties. So just for a couple of minutes, if we can just open it up so that you can put some comments in and tell me and the colleagues that are also attending what you think about using these different screening tools. So let me have a look. I'm gonna move a little bit closer because I need to read the box that's got the comments in. So now you can see me really up close. Thank you. So we've got people using cross-care. I'm just going to scroll back up. So quite a few people are using cross-care. So one of the hospices in Reading have very good links with a dietitian in the local trust. Oh, based on the Durham cachexia pack, and I remember that came out quite a long time ago now. I don't know if it's had an update, but it is a really, really useful tool. It has some really useful information in it and very useful for hospices. I remember when it was launched, it was probably about at least 10 years ago, working in conjunction with a dietitian. And again, there's a mixture of people using IPOS and not using IPOS. Let me just, yeah. Okay, so somebody's asked what IPOS is. So IPOS is part of a suite of measures, outcome measures, part of the OAK suite. So now I can't remember what OAK stands for.
Outcomes, Assessment, Complexity, Collaborative.
So I hope you heard that. Outcomes, Assessment, Complexity, Collaborative. And this is a piece of research work that's being run by the Cicely Saunders Institute in collaboration with lots of places across the country. Okay, and Marie Cooper's going to send a link to some information on OAK after this webinar. I certainly find it useful. And when people are referred to me, I will go to their IPOS and find out what their perception, the individual's perception of that problem is. So that can be quite a useful tool. So, yeah, and so this is JWH, nurses. Screening tools are good, but we have no follow-up to a dietitian or speech and language therapist. And I think that is a problem. And we're going to talk about that just in a moment. Yeah, and somebody else is saying it can take 6 to 12 weeks for your patients to get access to a speech and language therapist. So there are limitations. And part of the purpose of these webinars is to think about what can you do if you don't have access to dietitian particularly. So the final webinar in the series is about practical tools, practical things that you can do to support people with their eating and drinking, because I do realise that lots of people don't have a dietitian that they can get in touch with. What does IPOS stand for? Palliative Outcome Scale is what the POS stands for, and the I think they put, it used to be done by professionals and they put the I in front of it when it became, it's International Palliative Outcome Scale. And there are quite a few of them now being developed across different countries and within different condition groups. So some people are using IPOS and nothing else. Great. I'm just conscious of the time. So what do you do if you identify a patient who is malnourished? When should you refer on? So this is the kind of key question really, and I don't have a simple answer for this. I think what's important is that you know what's available in your particular area. Or somebody's just popped in, it stands for integrated outcome scale. Thank you for the clarification. If you identify that somebody is malnourished, because as I said at the beginning, it's not just about identification, it's what you do about it. I think even if it is going to take a long time to see a dietitian, I think from a clinical point of view, it is still really important to refer to the person's local dietitian. So if you don't have anybody that is in or comes into your hospice, that might be referring to the local community service. I know that community services can be very variable in their access times. So we're very lucky in Hackney and East London, which is where the hospice is based. Not only do we have the dietitian myself in the hospice, I have a colleague in the community who has 1 or 2 days a week dedicated to seeing palliative care patients. And she runs a clinic every other week for patients with palliative illness who are well enough to come to her. And she can see them within 3 weeks. So even if patients can't see me in the hospice, they are very fortunate that, well, we are fortunate that they can then be seen in their local community very quickly. I think building up links with your local community dietetic service is important. I know some hospices are kind of affiliated or on the same site as acute units, so and care homes, so it's trying to get people to come in. And then I also think there's something about developing business cases to so that you can, say, buy in dietetic services. Now, for some places that are quite small, I suppose you have to think about how appropriate is that. If you're a very small inpatient unit and you don't have that many patients who have got major difficulties, it actually might be better developing links out so that patients know where they can go to when they're not in the hospice, or that you can have some kind of consultancy service with a dietitian. There aren't any easy ways. As I said, in the 4th webinar, we will look at some practical ways to ensure that people's nutrition needs are maximised. So that might help you with your catering teams on a day-to-day basis. I think having link nurses for nutrition can be really, really useful. So if you've got somebody with a particular interest in nutrition who can maybe have a little bit more training, a little bit more development, and support the rest of the team to do the identification, work out when somebody does need referring to a dietitian, and help that pathway, then I think that can be really useful. I see that, so someone's just commented that Mary Stevens Hospice has just developed links with their community dietitian, and I think for many that will be the way to go. So well, I first started working in a hospice when I set up a service at St Christopher's Hospice. That was about 12 or 15 years ago now, but actually that came from St Christopher's talking to the community service to say, we think we've got a need here, what could we do about it? And we did some work together that ultimately resulted in 1 day a week dedicated time that St Christopher's bought in via a service level agreement. The service that I have at St Joseph's is similar but on a bigger scale, so we have 3 days a week. So setting up those links, okay? Yeah, somebody's just put in a useful website, and actually, yeah, in my final webinar, I will have links to quite a few places that you can get good resources from. So thank you, that's Louise, thank you. We'll add that one in, and we can revisit this when we come to the final webinar. Okay, so I'm going to wrap up now because it is about 1:45. If you've got a few minutes in your groups, if there's more than one of you, or if you're on your own, have a think about what are you doing in your hospice now, in your institution now. Is there anything that you think needs changing? Who could you go to internally to talk about whether you need a dietitian? How could you demonstrate the need? And also think about how can you make links with your local community dietitian? Do you know them? And get in touch with them, see if they can come in and see you, see what kind of setup you've got and what they might be able to offer you, formally or informally. I'm more than happy to share with anybody the process that we have used at St Joseph's. We increased from 1.5 days a week to 3 days a week about 4 years ago, which is when I came into post, through a really robust business case. And I now do a very detailed annual report, so I can demonstrate, certainly from a numbers point of view, how many patients I'm seeing, what kind of patients I'm seeing. So at some point, you know, I'm happy to find a way of sharing that. So I'd like to thank everybody ever so much. I hope that you found it useful. The next webinar, if I can just say, is scheduled to be on the, originally was scheduled for the 9th of November, but I'm having to change the date of that, so I'm going to push it back a week. So the next webinar, which is on cachexia and psychosocial impact of eating and drinking, that is going to be on the 16th of November at the same time. Still a Thursday, still the same time. So I hope that that's okay for everybody. As with the previous ones, it will be recorded and the slides will be available after the webinar.